Thank you, Mr. Chairman. I would like to thank the organizing committee for inviting me to present in this important meeting. And I think NOHA has a job that hasn't been finished yet, and that's to examine the migration of Sudanese doctors further north, which I think will be another day job. So the outlines of my presentation will be a brief background, then to tell you a little bit more about this emerging phenotype of type 2 diabetes called early onset type 2 diabetes. And I'll try to describe the challenges which face the management of these distinct patient cohorts. I might have time to tell a bit more about a new novel adipokine called visfatin and its relation to insulin resistance if we have time. And I will try to answer the question that Mr. Chairman that mentioned, but maybe in a brief way, looking into the fundamentals of success in research, the challenges, and basically, does it matter at all to do research? I have very limited experience with that, but I'll try to share that with my young colleagues, and then I'll bring you to a conclusion, hopefully. So type 2 diabetes is a syndrome of basically constellation of obesity, insulin resistance in the genetically predisposed persons. And unfortunately, because of unhealthy eating habits and also the lack of exercise, we have been seeing a pandemic of obesity. And this magazine in the time here showing this picture of this young boy who's quite obese, as we can see, and the ice cream that he's going to have will tell you the whole story. So as I said, obesity has reached a pandemic state, and parallel with the increase in obesity prevalence, we're seeing an increase in the incidence of type 2 diabetes. And as you can see here from the projections, in 2025, we're expecting to see around 300 million people with diabetes globally. So we do have a problem. And to tell you about the burden of early onset type 2 diabetes, type 2 diabetes generally in most of the studies will develop after the age of 40. But because of this pandemic of obesity, we're seeing now type 2 diabetes developing in children and adolescents. And the problem with that is really the fact that the duration of diabetes is an important factor in the development of the complications early on. And when I say complications, I mean microvascular and macrovascular complications. And I think a few of the pediatricians here would agree with me that it is a problem. I'll quote this study, which is a Canadian study that looked into 51 children who developed type 2 diabetes at a quite young age. And they were followed up between the age of 18 until 33 years of age. And the results were alarming because 9% were already dead, 6% were receiving hemodialysis, and one had 2 amputations, and one was already blind. Not only that, it has been shown in another study that the risk of having an MI if you have early onset type 2 diabetes is increased by 14-fold compared to the general population. And also, the fact that it has been long enough, the risk of having retinopathy is quite increased, as shown in this study here, which compared people who developed type 2 diabetes before the age of 40 and those who developed it after the age of 40 for the same duration of diabetes, which is 20 years. Those who developed it earlier had a significantly higher risk of retinopathy. So I think we do have a problem here. The metabolic research unit in St. James's Hospital, the unit that I have been working between 2005 and 2007, was led by Professor John Nolan, who's now actually the head of the Steno Center in Denmark. It has pioneered its research into studying the pathophysiology of insulin resistance and early onset type 2 diabetes. And when I joined, there was a study which was already up and running, and I continued with the group. So this is a group work. And the group has already published basically an important finding that exercise improves insulin sensitivity in middle-aged subjects with type 2 diabetes. And it resulted in improving insulin sensitivity by more than 50% and increasing glucose disposal rate. So the up and running hypothetical questions were, number one, does exercise improve insulin sensitivity and glycemic control in early onset type 2 diabetes? And the other question is, does it improve the markers of endothelial dysfunction in these patients? And the third question was to look into more newer biomarkers, and we picked visfatin as a new novel adipokine, whether it to be changed with exercise and whether that has anything to do with insulin resistance. So this is just the design of the study. I'm not going to tell you more about that, but at baseline, we basically did VO2 max, which is the maximum oxygen consumption capacity, body weight, lipids, A1C, vascular markers, and adipokines. And then we also performed basically muscle biopsies and hyperinsulinic clamps to assess insulin sensitivity at baseline, and then after 12 weeks of exercise, and then at the end of the study. So this is just the baseline of the study population, and as you can see, they're quite young, aged between 25 to 26. They're very obese, BMI 35 to 34.9, and they were very insulin resistant from the clamp data. I'm not going to go through that. So unfortunately, the findings were quite disappointing. Nothing has changed in the group of early onset type 2 diabetes. They haven't lost weight. Their A1C hasn't changed. And basically, they were very insulin resistant. Their insulin resistance has never improved. And they had a very marked defect in beta cell function. This is the first paper which was published. So the vascular markers, as I say, didn't change at all. And that means that they have the burden of developing cardiovascular disease later on. Interestingly, the adipokine visfatin, which is also a pro-inflammatory marker, has come down, which is kind of the only positive finding from that study. But as you can see here, it was further reduced in the diabetic group here compared to the control group. We'll come back to that later on. So it has no relation to insulin sensitivity from this study. There was no correlation. It was positively correlated with A1C, and basically there was a greater reduction, as I said, in the group with early onset type 2 diabetes. But the change in visfatin was negatively correlated with the change in VO2 max in a way that the greater reduction in visfatin would lead to a less change in the increase in the VO2 max. Aware of the time constraint, but we hypothesized that basically the failure of increasing VO2 max in the diabetic group, which was the group that we're interested in, must be due to a mitochondrial defect. So we went on and basically we investigated the same group with chronic and acute exercise studies, looking into mitochondrial genes, and we were able to identify that basically at baseline the diabetics had a defect in mitochondrial function, and that failed to increase with exercise, basically, and basically that would have implications in basically the design of the exercise training that you should give to this group of patients. That paper was published in Diabetes Care, and it's a big breakthrough into the pathophysiology of early onset type 2 diabetes. And we believe that this is likely to be due to the severe obesity that has been kind of developed from very early age, and that will implicate into the design of different kind of therapies to treat these kind of patients. So I'll skip a few slides because of time. So in conclusion, I hope I have convinced you in this very short time with skipping a lot of the data that early onset type 2 diabetes is a quite aggressive disease, and it is characterized by severe insulin resistance and a deficient mitochondrial capacity to respond to exercise. Visfatin from the skip data is likely to be a mediator or a marker of aerobic fitness, and it also could be a marker of cardiometabolic risk. However, we need further large mechanistic studies to look at this, and it could also be a therapeutic target. But unfortunately, I will not be able to show you all that data today. So back to the three questions, fundamentals of success. I think you need to be very motivated. You need to be very patient, because recruiting patients, having data, analyzing data, these are all very time consuming. So you really need to be very dedicated and very patient. You need to have the basic skills of Microsoft Office. You need to know a lot more about SPSS and EndNote, and basically, you need to know a lot of statistics. And I found myself, basically, you could read or go for a statistical course, but I don't know whether Safa would agree with you or not. But I think you need to apply on real data. You need to practice your statistics on real data, rather than you have a theoretical knowledge of statistics. And then you need to be coached by someone who has knowledge of statistics, like a statistician or anyone who is very senior. The challenges, I think funding is the main problem. You need to work in a unit which has funding, which has access to funding. Sometimes you might need to be doing some clinical trials to try to get some funding from the pharmaceutical companies. That has its own, will have its own problems. I don't think I can discuss that now. Regarding data collection, I think you need to actually make it easy for you to collect data. And I think research is not about I, it is about we, really. And it's never like a one-man show. Does it matter at all? I think it definitely does. Every presentation, every publication will be an addition to your CV. All the skills of research that you bring in with you are very important for you in your next job, in your career, in you as a mentor to train other people. And I think it is quite important to do research. There's no problem with that at all. So I'd just like to thank a lot of our collaborations, but namely I would like to thank Professor John Nolan, who led this research. And unfortunately, he left the country, but his legacy will remain, I think. And I'd like to stop here, if possible.